everybody see my slide already?
Yeah.
Okay, so because of the time, so I will just start my case sharing experience. So the first case is a 71 years old male patient diagnosed with HCC previously. He had a history of hepatectomy in Singapore, and he had a normal liver function test with the Child-Pugh score A. However, the recent condition that follow up the abdominal CT scan showing the liver cirrhosis, and also there's a liver mass, the hypodense mass with a clear margin in the segment 8, segment 4B, and the segment 5. But there is no the portal vein thrombosis. So the first pulling questions, if we face or found that this kind of patient, what is the best option then to all participants? So first, that whether you will advise the patient to undergo TACE, or maybe the combination between TACE and RFA, or maybe combination or between TACE and radiotherapy, and then systemic therapy, or maybe even the systemic therapy kind like immunotherapy. I think still not everybody's voting, not already, not yet. I think still voting, still progressing. Okay, so let's just see. So I think most participants chose TACE and RFA, and then maybe slightly different choosing the TACE and radiotherapy. So let's just continue the case. So the first time after that we did the telemedicine with also the Singapore team doctor, and then so it was decided that the patient need to do the TACE treatment in this case. And then the patient underwent the TACE, the first TACE treatment. However, seems after 1 month evaluation after TACE treatment, the tumor still progressed. So based on the interventional radiologist evaluation, this might be a difficult kind of tumor because it's the hypodense tumor. So then after that, the radiologist needs another advice for the further treatment. So in this situation, what to do next? Whether need to give in systemic therapy, kind like multi-kinase treatment, or maybe radiotherapy and then immunotherapy, maybe combination treatment between TACE and systemic therapy, or maybe we just leave it the patient for the best supportive care in this condition. So let's just see the pooling. Okay. So most of participants answered might be better to decide for the combination treatment. Okay, and then after discussing with the patients and then with also the interventional radiologist, the patient still not keen to have systemic therapy because maybe for the information for the Professor Tohan Chong that immunotherapy has not been started yet in Indonesia for I mean like standard HCC treatment in the guideline. So most of the patients usually will receive multi-kinase inhibitor treatment. So in this case, the patient still not keen to have like a long-term systemic treatment. So then from the interventional radiologist, he advised whether this patient can undergo the RFA treatment. So then we decided to do the RFA ultrasound guided with the new needle generation, like 3 needle octopus type made in Korean. However, after the RFA treatment, then the patient experienced severe abdominal pain. And then the patient also had liver function deterioration. And there were the presence of ascites with evidence of the hypoalbuminemia. So and then the patient examined by the radiologist through the abdominal CT scan. As we can see here that the multinodular liver mass, and there is evidence of the pseudoaneurysm at the right hepatic artery, peritumoral at the segment 5. And also the radiologist found there was a contrast agent extravasation, suggesting the rupture. And also from the blood test evaluation, there's a decrease of the hemoglobin level. So the patient decided to undergo the embolization and called treatment. After the treatment, the patient condition is getting better, and also the liver function improve. It's also getting better. So do I continue with the next case, or the panelists like to discuss first about this case?
So, how about the the patients now? Is he still, still live, or his conditions?
Yeah. Now thank you, Professor Rino. Now the condition stable. The patient still admitted in the hospital, but stable condition, and the clinical condition is getting better with the improvement of the liver function. So I don't know, maybe yeah, yeah. So maybe Professor Han Chong, you want to comment?
Yeah, no, thanks very much. I mean, obviously, this patient is incurable. There's no curative option. And, I mean, looking at the rupture, and of course, he was rescued from the rupture with embolization. I
Yes.
mean, of course, you do want to stabilize him, but if he doesn't have any pain or discomfort, I wouldn't do anything yet. That means if he doesn't have any discomfort from his cancer, I wouldn't do anything and just let him recover. But if his liver function is better later, I would still consider something. I mean, that's the problem with medical oncologists. We're always thinking about giving something. The issue, of course, is that I would not dare to give atezolbev because, you have a history of rupture, bleeding into the liver. I wouldn't dare to give atezolbev in this case. Maybe lenvatinib, even if lenvatinib is VEGF receptor inhibitor, the risk of bleeding is actually not high with lenvatinib. So maybe I might consider systemic therapy later, but not right now.
So maybe other panelists have any comment? Dr. Irsan, maybe? No? Prof. Rino, you still have any comment about this?
Yes. Yeah, this is quite interesting case, and how this case deteriorate after treatment. I think not really rare occasions. Yeah, so I agree with Professor Pan Chong that we should observe this case first for and hope that the liver functions improve well enough to plan for the next treatment.
Okay, so I think better I will continue with the second case. So it's a 71 years old male diagnosed with chronic liver disease since 2013. Hepatitis C related, has been treated with interferon. And I think he still has a very good liver function, kidney function. The abdominal CT scan in December 2017 showing the chronic parenchymal disease with fatty liver changes, with liver nodules and the right lobe, segment 5 and 8, and also segment 6 with the the size of the tumor is really borderline. The segment 5 through to 8 is more than a little bit higher than 5 centimeter, and also there's a possibility of the small nodules around the primary nodules, possibles like satellite nodules. But in this patient, is no portal vein thrombosis. And as you can see here, the AFP level is quite high. It's more than 6,000. So I think I will ask to the participant first with the polling question. What will you do? Whether you will ask for the surgical approach or maybe ablation, RFA, TACE, targeted or systemic treatment, or maybe just leave it the patient for the best supportive care. So please, all the participants to answer the polling questions.
So sorry, Cosmos. Can I ask you? You know, when you say metastatic nodules, would you mean metastatic nodules inside the liver or outside the liver?
Oh, sorry. Yeah, it's inside the liver.
Inside the liver.
Yeah.
Okay. So there are two lesions which are quite big, 5 centimeters or bigger, and then there are other metastatic nodules.
Yeah.
Okay.
So sometimes in several cases, we found patients with metastatic nodule around the big tumor. Yeah.
Right. Right. Okay.
So let's just see the polling. So most of the participants are choosing the systemic treatment, even though that still there are some participants thinking about the surgical approach and also the RFA or TACE. Yeah. So then the patients underwent a TACE for segment 6 and 8. And then the abdominal CT scan in January 2018 showed that the liver nodule at the segment 5-8 with the lipidol deposit and the partial intratumor viability and no more intratumor viability at segment 6. And I think not clear to about that the information about this I mean the previous the small metastatic nodules, and this patient still has a stable liver and kidney function. So to the participant, what will you do next? Yeah, with this kind of result, whether this patient should continue TACE treatment, RFA resection, multi-kinase treatment, or maybe immunotherapy. Okay, let's just see. Wait for the polling. Okay, so the polling result mostly, I think the participant chose the multi-kinase inhibitor treatment. Yeah, because as I mentioned previously that the immunotherapy has not been the standardized treatment and in the guideline, and just recently approved in Indonesia. So and then okay, and then this patient he chose to underwent a taste, and then you can see here that after 3 times taste period, so the AFP level from 6,000 to become the 1,246, and the patient had a stable liver and kidney function. After that, the patient didn't come. So in January 2019, the patient came again with the AFP level increased until 5,000, and then he agreed to underwent a taste again. Yeah, so the abdominal MRI in April 2019 showed that the size of the tumor seems to be decreased, but I don't think it's quite significant compared to before. But still, there was no ascites or no portal vein thrombosis based on the MRI evaluation. So then the patient being asked by the interventional radiologist to undergo the RFA treatment. So after the RFA, the AFP level decreased until the 298. However, during pandemic COVID, no further treatment, that the patient didn't want to come to the hospital, and the family also scared. So we offered for the multi-kinase inhibitor treatment, but refused by the family and the patient because of the possibility of the side effect. I think after that the HCC become progress, and last time this one is the imaging summary, just to show the image of the tumor after the taste and then the RFA treatment. And yes, this is the last tumor. I think is quite a good result, but unfortunately, because of the patient didn't want to come again to the hospital, so and the tumor progressed. Finally, the patient had the liver failure and passed away at home. So maybe Professor Han Chong, you have any comment about this kind of case?
Yeah, no, it's an interesting case, but I agree with you that when the patient was taste sensitive, you should continue to taste. I obviously don't do a lot of taste now, but after 3 tastes, you could tell that the patient responded. And then what was interesting to me is that when you started to give RFA, the alpha fetoprotein dropped very, very significantly to 200 over. So I think, with just local regional therapy alone, you were able to control his disease pretty well. So that was good and very interesting. I don't think it would have been wrong to give systemic therapy when his alpha fetoprotein went up after 3 tastes. I don't think it would have been wrong, because that shows that perhaps he's no longer taste sensitive, and perhaps a scan at that point would show that he's no longer taste sensitive. So systemic therapy would have been, I would say, acceptable. But as you say, the patient didn't want to have systemic therapy at that point. So in a way, you have to work with the patients to know what they really want. But no, I mean, obviously quite unfortunate that the patient eventually passed away though.
Yeah. So I mean, in your experience with the immunotherapy,
Yeah.
I mean, how about the mostly patient decision after you explain rather than multi-kinase inhibitor?
Yeah.
I mean,
Yeah. I think the data is still not out yet for putting systemic combination immunotherapy, whether it's atezolizumab or nivolumab or pembrolizumab. very, very early into our patients with local regional disease. I don't think we have enough data yet. There are two groups who are good friends of mine and my colleagues who did a study of Y90 Cersphere to downstage disease in BCLCP, followed by nivolumab. I mean, that paper is coming out very soon in Lancet Gastroenterology and Hepatology. And there is also now a movement towards giving atezolbev early as well, after TACE, or I think there are trials going on after Y90. So I think we don't have the data yet for putting systemic therapy very early on, for example, after a TACE failure with local regional disease. It makes a lot of sense to do it, because if you look at the Optimist trial data, if you have a TACE refractory HCC, but the disease is still inside the liver, if you start sorafenib early, you actually have a better survival benefit than if you keep on giving TACE. So I think it makes sense to give systemic therapy earlier.
Okay, thank you, Professor.
Yeah.
So, okay, let's just move to the third case. 61 years old male with diagnosed with advanced HCC non-viral related. You can see here that this patient still had a very good platelet count, INR level, increase of the D dimer, but I think with the liver function still quite okay, not very bad, because the bilirubin level is only above 1.5 a little bit, and then the albumin level still 3.2, and the kidney function still normal. So the CT scan showed the massive liver nodules spread across both of the liver lobes. However, no portal vein thrombosis or satellite nodule based on the CT scan. So, okay, to the participants in this case, so what will you do? Yeah? You prefer TACE treatment, targeted or multi-kinase inhibitor treatment, maybe combination, maybe possible of the immunotherapy, or maybe just leave it the patient for the best supportive care. So please vote in the polling. Okay. Okay, so I think most of the participants they prefer to choose the combination, yeah, between TACE and multi-kinase, maybe targeted treatment or systemic therapy. So, but then this patient, after discussing, then the family prefer just to receive the oral therapy. So then after 1 month, we evaluate the CT scan with the bilirubin level, I think still quite stable. So this is just to show that the CT scan, the before infantinib treatment and after. So based on the radiologist evaluation, it showed the partially respond. So it showed some hypoechoic of tumor, showing that less activity and some necrotic. Okay, so Professor Han Chong, what do you think about this case?
Yeah, no, I mean, obviously there's radiological response. What is the alpha fetoprotein before and after?
I think, if I'm not mistaken, this patient has a quite high alpha fetoprotein,
Yeah.
and then after it's decrease significantly, but still high, but I mean decreasing after the treatment. Yeah.
Yeah. So I mean, you know, he's only had lenvatinib for 1 month, right? Am I right to say that?
Yes. Yes.
No, I think it's a great response. I mean, obviously, you've only had lenvatinib for 1 month, your alpha fetoprotein is dropping, and your scan shows a benefit. I think it's a good sign. So just keep taking lenvatinib. One thing that was very interesting about the Reflect trial is that they did not accept patients with 50% or more involvement of the tumor of the liver. So obviously, they excluded very bad patients. But sometimes we will still give lenvatinib for a very large tumor burden if we don't have a choice or if the patient prefers oral TKI. So that's interesting. But yeah, obviously responding, so doing well.
Yeah. So I would like to ask your opinion. In your center, in
Yeah.
this kind of patient, would you
Yeah.
recommend to the patient, let's say, like directly to immunotherapy or?
Yeah. Well, no, I mean, to be honest, I would say in this situation, instead of lenvatinib, you can give atezobev. Yes, you can. I wouldn't say there's anything wrong with either choices. So Professor Kudo has shown data where you can give lenvatinib and shrink the tumor, even a large tumor, for resection actually. So you can actually shrink a tumor for resection, and assuming you have a fantastic response. So that's another thing that can even be considered if the tumor really shrinks very nicely.
Okay, thank you. So yeah, one more question, Professor Han Chong. After that three cases presentation, I saw that most participant is starting to choose or to prefer to have like a combination treatment.
Yeah.
So, is your opinion about whether that's the combination as the first line, or maybe you still thinking that still maybe better the single treatment as a first line first? Oh.
Yeah. I think the data for combination is coming out soon. There are many trials looking at different combinations. But I think the classical standard guideline is still to use TACE as the standard treatment for unresectable HCC with good liver function, BCLC-B. Of course, assuming the patient is not a transplant candidate, there are situations where you can use TACE to as bridging therapy for liver transplant. So the Hong Kong people have shown that if you give TACE to HCC patients, of course, and then they fulfill the Milan criteria. So you TACE first as a form of bridging. The patient has a good response, and the alpha protein drops. You can actually take a patient to liver transplant, assuming that the liver function. I mean, assuming that the patient fulfills the right criteria. So in a way, there are many things that you can do in the intermediate stage HCC. And I don't think there's absolute black or white or right and wrong. But I guess patient safety is important. But to combine treatments, it's possible. You can combine RFA with TACE. But when I saw an option of combining TACE with radiation, I wondered, do you mean by radiation, do you mean SBRT? Because external beam radiation therapy is obviously quite worrying for liver function. So usually for us, if you wanted to give radiation to a patient with HCC, we would give SBRT.
Yeah, yeah, I agree with you. Yeah, I mean with the SBRT.
Right. Yeah. No, I think every patient should be discussed, but I would say single agent modality is still the usual acceptable recommendation.
Okay, thank you.
Yeah.
And then I think this was should be last case. Yeah, 65 years old female with HCC, CLCC, non-viral related. She was diabetic, and imaging showed the hepatomegaly with massive tumor mass infiltration from hilar to left lobe, and the portal vein infiltration, multiple lymph nodes enlargement, and also the presence of the ascites. Normal bilirubin level, the albumin level still above 3. The interesting in this case that the AFP is normal with a little bit increase of the CA 99. And okay, I will ask the first time to, first to the participant, what will you do in this kind of case, whether it stays with targeted treatment or systemic, or directly to for systemic therapy, or taste maybe plus RFA, radiation, or maybe just leave a patient for the best supportive care. So please for the participant to vote for the
So,
pooling.
so Cosmos, you know, you
Yes.
said the patient at ascites. What is the Child-Pugh status again?
I think it's B to C. Yeah. I think it's
So a poor B or a C.
yeah, because
Okay. So,
the ascites is not so much. Yeah, it's,
uh-huh. But okay. But I'm sure the albumin is low as well, and maybe the bilirubin's a bit high.
yeah. So the albumin is around 3.1. So let's just see for the pooling. Okay, so again, that the most participant chose the case with the systemic or targeted treatment. So the patient prefer to receive only the oral treatment. So let's just see that this is the image before therapy. You can see here that is very massive tumor in the liver, and then this is 1 month after the treatment. It's surprising that there was quite a response from this patient received lenvatinib treatment. So even though that still not the ideal, or maybe the ideal response, but according to the radiologist, there was improvement and the response, even though that's not considering that very good response. Yeah. And liver function is, to, if I'm not mistaken, I remember that it's always stable. Yeah, the liver function. So the problem is then this patient had the severe hand-foot skin reaction with pain, and after 3 months, the dose was reduced because the patient could not stand with the side effects. And then, unfortunately, then the patient had the lung infection and passed away after 6 months. And then passed away due to the severe sepsis condition. Yeah. So maybe I would like to comment from you, Professor Han Chong, about this case.
Yeah. So, you know, if the patient was a Child-Pugh B or really bad B or coming to a Child-Pugh C, I wouldn't do a taste. I think it's too dangerous. So I think the decision was correct. It was a correct decision to give an oral TKI. But as mentioned, I don't think there's much data on the role of lenvatinib in the poor Child-Pugh. I mean, there is some data on Child-Pugh B status, but I mean, there is still benefit. But you're right, you do need to be careful. But no, it's amazing how they managed to get such a good response again within a month of treatment. But again, sad to see the patient pass away from sepsis and lung infection. Now, because you know, we tend to see this only in patients like given chemotherapy, like if you have lung cancer or colon cancer. But I mean, these TKIs are not immunosuppressive. So I mean, but it's a really tough disease. Ascites, bulky tumor. He did have a very bad disease.
Yeah. Okay. So yeah, I think, I think that was last case, but I would just like to I will comment about the most of cases in Indonesia that
Yeah.
that the liver function is still mostly maybe B, AB, but sometimes B or C, and then sometimes there was a vascular invasion or not, and then the amount of nodule mostly is more than 4, and the size also that's very big, just like Dr. Irsan said. However, that it was just recently published by our group, by one of the Secretary General of the Indonesian Association for the Study of Liver, Dr. Andri Sulaiman, that our experience with RFA treatment showing is quite good response, yeah, in the term of the survival. You can see here because most of patient also has BCLC B staging, and even though that some of patient has the combination treatment, but if we look and the response is 12 months and 36 months, is 12-month response is still quite good, yeah, because it's still above the 70%, yeah, of the patient, yeah. This data is combination data between Cipto Mangunkusumo Hospital as the government referral hospital and Medistra Hospital as the private referral hospital for liver cancer. Yeah. So I think I also would like to, your comment about this. About the RFA treatment, maybe in your center.
Yeah. No, I think I'm sure both our centers do a fair number of RFA, and our intervention radiologists will do that. I haven't read this paper, to be honest, but it's interesting how you have combinations of RFA with others. So no, it's nice to collect real world data and to showcase your outcomes. It's always an important thing. And then of course to sub-analyze the BCLC status. I noticed there were quite a number of BCLC B patients who also underwent RFA, and again more than 3 centimeters as well. Because I think optimally, and you can educate me about this. I think if it's more than 3 centimeters, the outcomes are usually not so good, right, Cosmas?
Yes.
And I think it's great that you guys are collecting and capturing this data, looking at your outcomes. As far as Child-Pugh status is concerned, again, I think, of course, Child-Pugh A is probably the safest, but you also have a fair number who have Child-Pugh B as well. And,
Yes.
and you also show pretty good outcome. I mean, at 36 months, 50% or more are still alive and well. So I think it's really nice to publish these sorts of outcomes data.
Okay. So I think, yeah, from me, see, last thing that where you can also make comment that in the development of the treatment, that sometimes I also often discussing with the medical oncologist that whether we make better or maybe making worse of the patient condition because of the side effect of the many multi-kinase inhibitor treatment, and whether this can be used in the very early stage, and where the patient sometimes patient also cannot accept that when they have to uh, I mean be treated for, let's say, like to take the oral treatment for the whole of their life, and whether this is really achieve the satisfaction result.
Right.
Yeah.
Right.
So maybe you can make also comment.
Yeah, no, I mean, systemic therapy definitely has more side effects than RFA. TACE, on the other hand, you have to be very careful with TACE. I mean, we've seen some patients who are given TACE, with Child-Pugh B liver function, and either they end up very neutropenic or their liver function just deteriorates. Again, at a high volume center like yours, I think I'm sure the patients are very carefully selected, because we have seen one or two in the last many years, 1 or 2 cases where the liver function just gets worse and worse with TACE. But I think systemic therapy, we'll have to wait for the big studies to come out to show whether systemic therapy in BCLC-B or a combination of systemic therapy and local regional therapy is going to be beneficial. My feeling or my intuition is that you will need to have both in an earlier stage. And to be honest, whether it's oral TKI or atezolizumab or single agent IO, I think generally most people can tolerate them pretty well. But like for example, your patient with very bad skin rash or mucositis, I think, and you needed a dose reduction, yes, we have seen that as well. And of course, with lymphadenate, you have to be careful with hypertension. Sometimes the hypertension can get quite out of control, and very rarely they can get thyroid dysfunction as well. So you need to check the thyroid function test. And of course, for atezolizumab, you do need to look out for the immune-related adverse events. But they're not really that difficult to do. That's why it has been done often enough by people who have experience and of giving these drugs, and then you can look out for the problems. Everything, as you correctly say in your first bullet point, is about a risk benefit. What is the risk and what is the benefit? And you have to find that balance between the two.
Okay, so I think this will conclude my talk about the case sharing experience. And I think I will stop share and then thank you. So I will returning back to Professor Rinogani and also the organizing committee. Thank you. Thank you, Professor Han Chong.
Thank you. Thanks, Cosmos.